Miigwech, Renee, thank you. So would you mind introducing yourself, Renee?
My name is Renee Bolio Banks. I've been at NACC for about 2 years now, and I'm one of the elders and residents. So I do spiritual care at the clinic, holistic healing. Thank you.
Miigwech. And Dr. Meyer, would you introduce yourself? Oh, you're muted. Hey.
Even when she unmuted, we couldn't hear her. So she must be having some audio issues.
Yeah. Speak now, Dr. Myra. Dr. Myra, do you want to try? No? So Dr. No? Okay. Well, we're glad to have you here, Dr. Myra. Dr. Myra's with Red Lake. And then Michelle, would you introduce yourself?
Of course. I'm Michelle Corcoran. I'm the nursing supervisor for the MAT program at NACC. Thanks for joining us, everybody.
Thanks. Beth?
Hi, I'm Beth Ryan, and I'm the Project Echo coordinator. So if you have any questions, please feel free to reach out.
Oh, someone's unhappy.
And I'm Kari Rabi. I'm a family practice physician and addiction medicine physician here at NACC. And with that, I will start the slides. Give me 1 second.
Sorry, I was finally able to figure out my...
Oh, could you introduce yourself, please?
Hi, this is Dr. Laurel Myra, and I'm the director of the Minnow-Bidisi-Win Wellness Clinic here for the Red Lake Nation in Minneapolis.
I'm so
Welcome.
Glad I'm so glad you could join us. We missed you last time. So I'm going to go ahead and share my screen. Okay, so this is the Midwest Tribal Echo. Today, we've already had our prayer and land acknowledgement. I'm going through introductions and agenda and the Zoom guidelines. Michelle will be doing our announcements today. Dr. Grain will be joining us to talk about micro and macro inductions, which is a very, very rapidly changing area in MAT and Suboxone. If we have time, he'll do a case presentation and then we will close. I think we're all pretty familiar with Zoom. However, in case you aren't, you can please introduce yourself in the chat function, put your name, title, organization, and email, just so we can sort of keep track of you and any CME or CEUs. You can update your name on the screen, right click on your image and rename yourself. Also, please turn your camera on so we can see you. It just makes for better communication as we go through this learning process. And mute your microphone when you're not speaking, and we will mute it for you. Just don't take offense. It's just so that everybody can hear better. And then no protected health information, please. Michelle?
All right, sorry, there we go. Technical difficulties. So I want to let you guys know about some other echoes in case you're interested. So there's, this is a collaboration between Hennepin and NACC. And so these are some of the Hennepin echoes that they do. They do a viral hepatitis echo the first and third Tuesdays. And then they also have an integrated opioid echo that they do on Thursdays. So that information is here. You can always just email Midwest Tribal Echo if you have questions about Hennepin echoes, and we can get you to who you need to see or talk to. Next slide. Case presentations. We haven't really been getting to these much, but certainly they're a good learning opportunity and a good tool for discussion. So you're welcome and encouraged to send us case presentations or clinical questions that you want to discuss during a session. The form is on the Hennepin Healthcare Echo website, or you're welcome to email us just the information, or if you want the link, we can send it to you. So next slide. Continuing education. You will after attending a live session, get an email with a survey. Once you complete the survey, the education department hangs on to that, and then we'll, like 2 or 3 times a year, send out CEU credit to those who attended and also filled out the survey. That's the only way they'll know or be able to record that you attended and give you the credit. And that is it. I think Dr. Grant is running late. Let's check in with Beth here.
Hi, yeah, it looks like Dr. Gran is in clinic right now. I know we had a case on the back burner. Did we want to discuss that, or would you like me to pull one up?
So, oh, you're muted, Dr. Robbie. We have the case in the slides.
It is Dr. Graham's case though,
Sure.
but we can start with that.
I can read it and we can just chat.
Sure.
Yep.
Okay. Do you want to pull up?
Yeah, give me 1 second.
Yeah.
All right.
Okay. So the key question for this case is, how would you approach anxiety and impulsivity?
Okay.
Oh, here's Dr. Graham. Never mind.
Excellent timing.
Ah.
Hey,
Hi,
ma'am.
Brian. We were just about to start your case, but we will hand the slide set over to you. Let me make it possible for you to share.
Nothing like hitting the ground running.
So Brian, you should be ready to go.
Sorry, I had a glitch in my sound, so I was just trying to fix my sound.
You sound good now.
Sorry, everyone, again for my delay. Can folks see my screen?
Yes, we can. Thank you.
So thanks again for being able to join you all, and thanks for your time and thoughts. Today I was joining folks to talk about just alternative, although depending on where you work, either alternative or the new standard approach to buprenorphine starts. And I think just because there's been so much rapid change and ongoing evolution of how people think about starting buprenorphine, my goal for today is really to talk about all these different approaches to initiating buprenorphine for people who have an opioid use disorder and ongoing opioid use, and then talk about how to think about it. So one, I don't have any financial conflict of interest, and I'm not going to discuss anything off label. But my objective is really just to kind of go back to those first principles of why do we do initiations the way we do, and then to talk about different ways from why what we're doing now may differ, and different approaches people are thinking about now compared to traditional buprenorphine initiations. So hopefully this is going to give a different cognitive framework for how to think about what you will inevitably see changing in the next several months to years, because it will change. So traditionally, you just kind of give like some standard baseline. Historically, the education that I've received, it's been kind of the standard training all through waiver trainings, even till today. Well, I guess now there is no standard waiver training, but like until that training got waived, the waiver trainings that were required all said universally that the way to start people is you wait 3 to 5 half-lives from the current full opioid agonist. So whether that be fentanyl, and it traditionally has been considered a very short-acting opioid because the way it's used in very acute circumstances during surgical procedures where it's very quick on and off, or slightly longer in terms of oxycodone, or even more so if you have like long-acting OxyContin and other things. So 3 to 5 half-lives of the current opioid agonist in an opioid tolerant person. I just say that up front because people that don't have a history of opioid use, it doesn't matter. So if I just took 3 oxycodone, I can give you buprenorphine right away if you've never taken oxycodone before, and it won't actually change much of anything for you. But for the person who's used to getting a certain higher amount of opioid, they have an opioid tolerance, then you're kind of trying to figure out that gap, and I'll go into more of that. Then you wait for moderate withdrawal. So it's both a time setting, so usually at least X amount of time from the last opioid use, as well as you're having at least moderate withdrawal symptoms. So usually the clinical opioid withdrawal scale, or the COWS scale, of at least 8, although historically people have said for chronic fentanyl use, it may be as high as like 13 or more is what you should be waiting for until you start your first dose of buprenorphine. And when you get that COWS score of either 8 or 13 or whatever anybody's given site looks for, you start out, you give 4 milligrams of buprenorphine / naloxone sublingually. And then historically people said even just give that 1 dose, and then you might give a second dose on the first day. So traditional teaching is 8 milligrams max first day, 12 milligrams max second day, 16 milligrams max third day, and you kind of go from there. I think protocols have varied widely and are oftentimes more aggressive than that, but that's the traditional standard textbook. This is what you should do. But even when people repeat as needed faster than that, and the basis for, by the way, that slower pace is that buprenorphine can take, and it will build up over time. And so you get a higher steady state the longer you stay at any given level. So what you feel is your normal at 12 milligrams will be different 3 days after 3 to 4 days of 12 milligrams than it is on day 1 of 12 milligrams. So there is that kind of slow build of stacking essentially for what that dose feels like for any given patient. So kind of, but matching, depending on where you are, aggressively kind of increasing that dose of buprenorphine until the patient feels better and more normal, or at least doesn't have withdrawal symptoms. So why make it harder? Like that was pretty sweet, like 4 + 4 + 4, like it's pretty straightforward. So like why deviate when already we're struggling to get people access to care? Why not just make it simple, straightforward? Because that would be really nice. So nobody wants this. So this is my favorite drawing of opioid withdrawal, because if you look at that, like nobody wants that. It looks horrible. Even though like when you, by the way, I'm sorry, my phone has got like constant chatter. So hopefully you don't get too much random stuff. But when people describe this just as like the straight up symptoms of opioid withdrawal, it sounds like, and everybody's here's probably heard this, like it sounds kind of like the flu. So like, what's the big deal? And oftentimes it's because of this central sensitization that people have from being on chronic opioids, that any given new noxious stimuli feels extremely worse. So what you and I make feels like the flu and being a really bad day. It seems like the end of the world for many of these people. And it really does feel horrible. And so this is kind of what you want to avoid, because if you give buprenorphine too early in that procedure, then you precipitate withdrawal, and you don't want to put your patient here because you're starting them on buprenorphine. So the whole goal of this new conversation around how to start buprenorphine is trying to figure out, because it seems like people are having a higher likelihood of having precipitated withdrawal, and people don't want to do that to their patient. You don't want that to be the person in front of you. And I just realized, thank you for giving the heads up on the presenter view. I don't know how to do that.
Is it display settings? No. It's under slideshow at the top. And then you should say,
Oops, I meant to say from current slide.
there you go. There we go.
And so the whole goal is to try to avoid precipitated withdrawal. And so here's kind of like one standard way. This is what was initially created by the Yale Emergency Department. So this is their one-page handout that they give to all of their patients when they come into the emergency department and they're doing a home induction. This is the form that Yale gives out. And why I cite Yale is Yale was the first place that did a large trial of buprenorphine initiation in the emergency department. And most of those were home initiation. So they gave this to people and they really had no documented major significant adverse events. It was just as likely you were going to have precipitated withdrawal during a home induction as you were waiting and doing it in the emergency department. So they decided just do this all at home. And so you kind of can see there, step one, take the first dose, wait 45 minutes if you need it, take a second one, and then they say go up to 12 the first day. So, but kind of the questions of like, when is opioid withdrawal not tolerable or feasible? And this is kind of one of the questions is theoretically for all those home inductions or home initiations to work is that you have to wait for somebody to be in more significant opioid withdrawal. And so there are some circumstances when people wonder, like, is this tolerable or feasible? And so one, if people have like really poor cardiovascular capacity, like ejection fractions of like 10 or less for their heart failure, or maybe 15%, but really low ejection fractions, so that they wouldn't be able to tolerate the physiologic stress of withdrawal. If they're mid-late third trimester or like really high risk for premature labor for whatever reason, maybe you don't want to risk them even going to moderate withdrawal to potentially precipitate labor. Some people have said increasingly, what if people are on really high doses of opioids with tolerance? Is there such a thing as being on such a high dose of fentanyl that you have a hard time getting on buprenorphine? I think there's debate about that as to what that really means physiologically, but I know that's a common thought process. And then maybe the patient's just unable to tolerate withdrawal. Maybe the idea of waiting for 12 hours or longer, or 24, or waiting until your COW score is really like 12, that just may be intolerable for people. So if they have really low distress tolerance, maybe that's a reason to say, maybe we just can't wait that long. And sometimes it may be that illicit drugs aren't acting as expected. And I think increasingly people are wondering about what's the nuance with fentanyl. Because whenever this has been reported, and by the way, nationally and regionally, the variation in people's experience with fentanyl is extremely variable. There are parts of the country that have very high fentanyl saturations that get almost no reports of precipitated withdrawal with standard inductions. And there's other places that are saying that people are really having precipitated withdrawal with like 2 milligrams of buprenorphine. So it's really hard to understand what's really happening. But clearly, the illicit drugs aren't acting as expected all the time. So is that just because we don't understand the drug well enough? One question around fentanyl. Historically, as I mentioned, people kind of, the general education for providers around fentanyl was all the studies that were done as a perioperative medication. So they gave it brief both boluses for people. They didn't have significant opioid tolerance. They gave it, they stopped it postoperatively, moving on. Or maybe it was like a PCA for like a week, but nobody was really given it for a long period of time. And increasingly, we're seeing people, whether it be like pressed fentanyl, like M boxes or box 30s, or whatever the perk 30, whatever the name that you want to call it, but it's on the street. It's just different. And so here's the first study that was published just in the spring of last year. So it's about a year old, by a group that said of 20-some people that were admitted to a residential treatment program, psychotherapy-based treatment program, and they got blood draws daily as they initially, and they said they used all the way up until the time of admission. So through that time, they then kind of tried to measure their fentanyl level and see when it actually was gone. And interestingly, they saw people with long-term IV fentanyl use, the fentanyl wasn't totally eliminated, meaning it was detectable out to about 7 days. And norfentanyl, which is traditionally thought to be a non-bioactive metabolite of it, was eliminated up to 13 days afterwards. Yet historically, people thought it was like much shorter, as you can kind of see in the top few bullets there. The question mark has been, though, are those really low levels clinically relevant? At what level of fentanyl does it still have bioactivity that would saturate a clinically important number of mu opioid receptors? That is not actually a well-established question. So we don't know. It's a really provocative study that really kind of begs the question, should we be waiting to start buprenorphine, or think about it differently, even like 5 days out, 6 days out? It's interesting. So all this goes back to saying the whole premise of this, and even why I showed that last slide, is do we need to wait until the fentanyl is faded out 5 days later to start buprenorphine? Because the fear is if I start buprenorphine too early, then I precipitate withdrawal. And nobody wants that, because oftentimes that's the patient who never wants to stay on therapy, says buprenorphine doesn't work for me. Well, taking a step back then and saying, well, what is precipitate withdrawal then? How do we even really think about what's happening? Is it just any buprenorphine at all precipitates withdrawal if there's other opioids on board in an opioid tolerant person? And it's not really that. So as I was starting to mention, precipitated withdrawal requires opioid tolerance. So with opioid tolerance, you get a reduced mu opioid receptor activity. That's mu opioid receptors, MOR, in several brain regions. And then it actually upregulates with tolerance the number, so you have a higher number of total opioid receptors. And this varies a bit by the type of opioid, but for fentanyl, this is true. And so precipitated withdrawal is then when you have more receptors that are out there, if you have a rapid reduction in the signaling. So, and what happens when you bind the receptor by an opioid like fentanyl, then you kind of, the signaling from that receptor kind of cascades through all the different cells and says, we need to do X, Y, and Z. All these different things happen from that receptor binding. So you just have to have a rapid decrease in the downstream signaling from that receptor. So if you go from like 100% saturation to 50%, or even if you go from 100% saturation to full saturation, but less activation, like with buprenorphine, are you still potentially precipitating withdrawal? So here's a visual way to think about it. So at the molecular level, when you bind those receptors on the far left-hand side, that's like fentanyl or any full opioid agonist. You bind it, it's active, it kind of goes forward. And you can say that like orange pentagon is like the full activation. And then the question then is like, if you rapidly push all those off and change it to like buprenorphine, so then even though you're fully activating all of those receptors, you're activating it at like 50% of what was previously happening. So suddenly, even 20 minutes later, you can kind of see the pictogram there, that's an unhappy patient. Suddenly you're precipitating withdrawal, even though you're activating many of the receptors. It's just less downstream signaling. So they're giving less activity, even though they're binding all of them. So again, what's happening with buprenorphine, it actually it tightly binds the mu receptor, but it only inefficiently activates it. So it only like activates about 50 to 60% of the signaling cascade for any one moment that it binds that receptor, and it sticks there. So it's slow to come off, and it sits around the site a lot. So anytime you introduce buprenorphine, it's just going to hang out and it's going to kind of muck up the activation. Everything is going to go slower when buprenorphine's around. It doesn't eliminate fentanyl from binding, but it just decreases it. And so at the receptor, then it just competes. So this, and some of you have heard me say this before, it's kind of like in basketball terms, if you're old school, it's like Dennis Rodman, or new school, you're talking about like Drummond, where it's just like it's hard to get a rebound, but everybody will still get the rebounds. So that everybody else on the court is still going to get rebounds. Just one guy's going to get a lot of them. If you're going to music, it's like the accordion at the symphony. Like you're going to hear all the other instruments, but you can't not hear the accordion. It's always around. And so everything else is just decreased in your perception of them. So here again, it's that the bridging and trying to get up to the microinduction is it's just slowly up titrating the buprenorphine without that significant rapid displacement. Is the difference between the far left-hand side and the right-hand side, is the difference really because it was rapid? And the argument for that is really how many of those opiate receptors are displaced? And the question is are you going too fast, too much? And so this is interesting, even clinically around town, I've had many discussions with a lot of different people around microinductions, or this like, how low can you start somebody? And interestingly, it seems like 2 milligrams is this like magic dose. I've had people that have been able to keep people on 1 milligram multiple times a day, even when they're taking fentanyl actively, and it doesn't seem to bother them that much. But as soon as the patient gets that first 2 milligram dose, it just seems to precipitate them, throw them into a bad spot. So is it really the fact that 2 milligrams on a population average displaces about 40% of the receptors. Is that just too much? Whereas even if you go down to like 1 milligram, it's only about 20% displacement. So is it because it's too much displacement that's happening at any given one time? And if you reduce it by 40% or maybe 30% or whatever, who knows how much, is that really what's causing the problem? Because I've been able to start people on 0.5 milligram, 1 milligram, even multiple times a day. And I've never had anybody complain too much, even in an inpatient setting where people are getting active like fentanyl PCA, so fentanyl drips. And people tolerate it, they feel kind of slightly off, but there's no kind of precipitated withdrawal with that degree of initiation. So it seems that precipitated withdrawal with buprenorphine is too much, too fast. So then what are different ways that at least we here at Hennepin Healthcare have been able to start people? We've had different protocols that we've tried. And so here's a couple of the different ones that we've done. And we don't have a standardized approach right now because we're just trying to figure out what it is. And we've got hopefully a pharmacy trial coming up here next year, the next several months, that we'll be able to get going to actually test some of these. So with IV buprenorphine, again, these like low doses initially, and then repeating it a few times a day, and then gradually building it up. That's 100% bioavailable versus sublingual, which is much lower, probably around like 30% or so. Whereas this, you can kind of see that sublingual protocol, you can kind of see there. And again, this is an inpatient. Other things that have been published where people did it in controlled settings, where they had B-trans patches available, people would stack B-trans patches. So they'd put multiple 20 microgram patches on day 1, day 2, day 3, and kind of go from there. There was just recently, I think last month, a study, or I don't know if you call it a study, but I guess it was kind of a mild, like a small study done in an inpatient in Oregon, where they did a 20 microgram B-trans patch for 24 hours, and then they just started from there with sublingual. And I know a similar trial is going on at Boston Medical Center, where they do B-trans patches for 24 to 36 hours, and they rapidly escalate with sublingual up to 12 milligrams or more on day 2. And they've found a lot of success with that without significant rates of precipitated withdrawal. So then how do you do that in an ambulatory setting where technically you can't order B-trans, and B-trans oftentimes has a prior authorization to it, and it's harder to, you can't get a B-trans patch for opioid use disorder. That's technically illegal. It's only for chronic pain where you have 24/7 pain. So what are different protocols that you can use for sublingual? And here's some of the things that have been tossed around here. And I think we've had different levels of success with different approaches, and we're still playing with this. This is what we've been trialing with overall good results. We've had a couple of people on the right-hand protocol where they did fine on the 0.5 and they did fine on the 1 milligram. And again, that first 2 milligram, and they said they have a bad outcome, even though theoretically they've built past the 40% mark. But for whatever reason, there's the rare individual where that first 2 milligram doesn't go well. And I don't really have a good rationale for why that is, but it's interesting. But overall, this has been quite successful for us. Interestingly, separate from all of this, our standard protocol for people coming in off the street, no matter why they were there, we only do the inpatient microinduction if somebody is actively on a PCA, is actively being prescribed other full opioid agonists. We do not do this for people that came in off the street from fentanyl. Our standard protocol then is you wait until an X amount of CALI score. Usually it's between 8 to 10, sometimes 12, but usually we're sitting for around 10, depending on what the circumstances are. And when the CALI score is 10, we start with 2 milligrams. And if they tolerate that within the next half hour to 60 minutes, then we ask the nurses to give another 6 milligrams and then kind of move from there. And we have yet to have precipitated withdrawal on the floors with our consult team. And And so it's hard to understand why we have had no observed precipitated withdrawal with that 2 milligram start in a controlled setting. And we do the same thing in the emergency department where we're starting people and we've yet to have precipitated withdrawal in the emergency department reported either. So it's hard to reconcile what we're seeing there in the inpatient consult service and the emergency department with kind of the experience many people, including ourselves, are having in the ambulatory setting, where people are coming into the clinic, or we're doing a home induction with the same, seemingly the same induction protocol, and yet things aren't going well. So if people are interested, I can send out this paper from Ghosh. This is originally a paper describing conversions from people on methadone chronically to buprenorphine, which essentially is the same principle of like, why should this be so hard? But trying to do that transition. And there's a whole variety of different pros and cons for how to do this. And I can send this out. To put one more kind of like flip on this, interestingly, the treatment for precipitated withdrawal, which is the thing we're all trying to avoid by doing these really low doses, is interestingly give more buprenorphine. So if you think about it here, our goal is to try to stay on this low end of the curve. But if we do go too fast and we give them 4 milligrams, there's two options: either sit there and let them kind of like suffer and try to give them adjunctive meds to try to like decrease the suffering, but just wait longer before you give them another dose. Or you can say, well, we're here, might as well just go all in. And most consistently, if you give somebody 24 to 32 milligrams of sublingual buprenorphine, they actually see their symptoms largely resolve. They don't feel great, but they feel much, much better. So alternatively, then the question is, if the question is receptor activation and we just need to flood the receptors, should we actually try to do this very slow incremental and inch somebody up this curve going from right to left? Or once they're in a certain degree of withdrawal, should we just go for it and give them 24 to 32 milligrams and saturate it? Because that's what we're trying to do eventually anyway. Interestingly, just a couple case reports now, there's been no formal studies that I'm aware of, but there are emergency departments, including like Alameda County, so that's Oakland, California, starts everybody with 16 milligrams in the emergency department. There's a program in New Jersey that does the same thing, where they start people at 16 milligrams right out of the gate. Some clinics also start with higher initial doses. So it's kind of interesting, this question of, should we be trying to go low and start kind of the start low, go slow regimen that's most common in medicine? Or is there a role to say for some people who may be really high risk with that longer tapered gradual increase, if for either a reason of cognitive impairment or unstable psychosocial situations or other reasons medically, should we just go big right out of the gate? And I think right now, I'll be honest, we just don't know. And that's why I say you're going to see a lot of different change in the next while, but I think it's helpful just to kind of have that conceptual framework for like, why are we doing all these crazy things that seemingly are counterintuitive, where some people are starting really slow, some people are starting low but going faster, and then some people are going really big. And I think it's kind of, to a certain degree, it's hard to really understand where we're going. But I know there's lots and lots of discussion about like what's the right thing to do in all these circumstances. So with that, I'll kind of stop and see if there's any questions or comments.
Has anybody who's been working with patients in the community, anybody who's on today, have you guys been seeing precipitated withdrawal? Have you been hearing about it?
I would like to share an unsuccessful, actually 2 unsuccessful attempts with the same young lad, late 20s, heavy fentanyl. So I live, I'm Shelley, I live up north in Bemidji. And so we have a lot of, our fentanyl is just, everything is tainted with fentanyl. It's got meth, it's just really bad stuff. I mean, people are not taking fentanyl here. They're making trips to the cities. If they're going to use fentanyl, they're going to go get it or suffer the consequences. So I'm excited about this whole topic, yet I tried 2 unsuccessful times. One, the last attempt, this young lad, I gave him 2 milligrams. He had, all kinds of therapeutic meds, you know, that he picked up from the pharmacy the day before. He had come in and his cow score was 15. He was a mess. He stayed in the office, lights off on the gurney, kind of 2.5 hours, taking his antiemetics and everything. And I got so nervous for him. I ended up having to call the ED and take him by ambulance. It just was horrible. So like he trusted me to come back twice to do a micro induction. So then when I hear you, Dr. Grant, about this go bigger, like he was already feeling crappy. Like that's the only thing I didn't do is say, you know, you've tried it too little, you know, the kind of puppy dog doses, let's just go all in. It was not good.
And actually one question that I throw there was an interesting provocative discussion I had with our fellowship group, is the question of when to tell people to stop taking their fentanyl. Because interesting, like, so what we do in the inpatient wards is like people are on PCA, so they keep taking it, and then we just start low with their buprenorphine, and we don't tell them to stop the other one until they're at a therapeutic range of their buprenorphine. So the other thing for that guy might be, and this is where sometimes it's a tough sell on the street, is keep taking your fentanyl, but I want to start you low on your buprenorphine, and I promise you I'm not going to make you sick. Because the message we've been giving them is don't take buprenorphine because it's going to make you sick. And now we're telling them, take a small enough dose of your buprenorphine, it's not going to make you sick, but keep taking the small dose and build it up, build it up, build it up, and don't stop taking your fentanyl until later. When is exactly is later, also a point of debate. Some people would say don't stop until you're at a therapeutic dose of buprenorphine. So just escalate until you get to 16 milligrams and then stop. So I don't know, Kari, if others have other thoughts.
Yeah, so we've been doing a lot of micro and macro inductions in the clinic, and we really talk with each patient, because what we're finding is there's such an aversion to the patients have very strong feelings about the buprenorphine, and because if they've experienced precipitated withdrawal. So we've done a lot of the slower. We do 0.5 the first day, and then 0.5 twice a day, and then 1 twice a day, and then 2 twice a day, and we tell them to continue to use the fentanyl. A lot of we have the luxury of having a dosing clinic, so a lot of times we observe at least the first dose, so then they feel more secure if we can observe them taking it and make sure they're going to be okay. We also we have moved, like, this is an evolving thing for us as well. So we have also gotten very comfortable with the macro induction, and we've been doing 32 milligrams out the gate. And that again is a part of a discussion. We offer that to the patient, like right away. We're like, this is the way you can do it. But if especially if we sort of sense that they have a complex social situation, they're unsheltered, they're gonna have a hard time with sort of doing the micro induction. We have given some people the macro induction right out of the gate, and they do fine. We had one person end up in the emergency room with psychosis in the evening, but we kind of, with his history, we're not sure that was at all related to the Suboxone. And then Michelle, was there somebody else who had a negative? I think he was the only one who had a negative. And I think we've about 5 or 6 macro inductions, and they've all tolerated it really well. So the question we're asking ourselves is, why do the micro induction in the first place if people can go straight to the macro induction and have none of this horrible withdrawal, and none of this dinking around with it. And then also for some of our patients, they've come into us and they're like, I'm done using, and then you're asking them to go back out and use some more, So we're measuring all of this with every patient that comes in. And then some patients are like, no, I don't trust the macro induction. They want to do the micro induction. So all to say, for us, it's about having the conversation with the patient and then creating a plan with each individual patient that suits them. And very interesting that very interesting that the macro induction works given the whole mechanism. It's very, as Dr. Grant said, it's very confusing. And actually, Dr. Grant, your explanation is probably the best I've heard yet as to like how to sort of conceptualize it as we go along.
One of the things I've kind of observed with working with you, Dr. Robbie, and some of the other providers, so the patients that can't go even a couple of hours without using, they seem to do better with the micro inductions where you just are slowly adding in small amounts. And then the folks who go, 8 to 12, 24 hours, whatnot, without using and are already in withdrawal, they tend to do better with the macro inductions. I'm trying to think, I'm thinking there's somebody who did a macro induction. So they weren't fully in withdrawal. Their COW score wasn't super high, but it was like 8 or something. And then the macro induction, they felt not so great. Whereas the difference in how they feel before and after the dose is not so different when they're already really sick, if that makes sense.
Yeah. Yeah.
And I also just want to acknowledge, I think one other subtle point in this that I'm doing a training for some ED providers here soon. And one of the questions that I think is really interesting is inherently when you think about the COW scale, there's some really subjective points in there.
Mm-hmm.
And so I think it's actually not a particularly reliable inter-rater scoring system, like how I do it versus Michelle or Dr. Robbie. Like it's pretty variable.
Mm-hmm.
So I think it's also acknowledging trying to be pretty conservative in the way that you score. Because I think if you look at it and you're trying to get somebody on, you can actually overscore somebody, or if they're already sick with cellulitis or some other thing where they have a systemic stress, you can get people to a pretty high COW score pretty quick, and it may not actually be related to their opioid withdrawal. So I just want to acknowledge there's no study or like regimented way to approach it, but I think it's just helpful to acknowledge that a COW score should be taken in context.
And I work so hard to, like, I underscore my folks. I know I do, because if withdrawal is the goal, I mean, you have to prove to me that you're so.
We just had a young lady who admitted to treatment and had been in treatment for 2 or 3 days. I don't remember exactly. And she came to us very much in withdrawal, and her COW score, I think when we did it, was like 15 or 17 or something like that. And she was, visibly very ill. She did not feel good. Her pulse was, over 100, just sweating. And we thought, well, obviously we can do just a regular induction. And so we gave her 8 milligrams and she got sicker. And then we gave her the macro induction. We gave her 32 total, and then she got better. And it was just fascinating to see somebody who hadn't used for days get sicker after getting 8 milligrams. And it was pretty eye-opening, because it was, I think, really the first one that I saw really get much worse after taking a dose. So that was interesting.
And was in treatment. So we were really, with some of our patients, we wonder, it's very difficult with the fentanyl not to dose frequently. So there's always a question, do they really, and then we've had patients tell us, yeah, I haven't used for 12 hours. And then after they have precipitated their withdrawal, they're like, well, yeah, I did actually use, this morning at, at 8 o'clock. So there's always that question in your head, but this young woman was in an environment that we really believed that she had not used for those 2-3 days.
Dr. Grant, I keyed in on the point where you said that, you're seeing a very different response in the ambulatory setting that you do in the inpatient setting. And there's just so much psychology, I think. Is it because you can, just a button away is some Zofran, or there's that your wraparound care? Is it just and we're looking at a freestanding clinic where we have, inductions, overnight, just kind of a detox set, not necessarily detox, because we're going to try to initiate, because we don't have room in the ER, but you can't admit everybody to initiate, Suboxone. So what do you do? But there's that's a very intriguing comment about you have higher success with the same program in-house than you do ambulatory.
And I think to a certain degree, I wonder about selection bias, like, because people in the hospital are also sick for other reasons. So I think we may not be catching as much precipitate withdrawal because people aren't scoring as high. They think it's for other reasons. Like, I think it's pretty consistent because our addiction council team is following, but I think there's some noise in there. So I don't take that fully. I state that because like we've never had anybody call it that. And there's always another alternative explanation. But at the same time, like it's just so hard for me to believe. And at the same time, there's like a large implementation study done on buprenorphine inductions nationally that's done like thousands of patients, which Hennepin is one. And actually we get a lot of flack from the national study coordinators because we start people, we convinced our ED to start people on 2 milligrams first and then give another 6. The study protocol is actually start with 4 and then do another 4. And it's the people at Yale that are the study coordinators, the lead principal investigators, and they actually give us a lot of flack for starting with 2 instead of 4. And they say they're hearing no significant rates of precipitate withdrawal in the ED study nationally. And so that's where it's just such a hard, like, what? Like, how do you reconcile that when clearly people locally are having a very different experience? And that's where it's just so interesting, like, how do you wrap your head around that? Or are people just not acknowledging what they're seeing? Like, it's really hard to, but clearly we're all seeing it.
Yeah. And then it's, not that, like when we look at our UTOXs, we used to see 6-acetylmorphine, codeine and morphine in every, and then some fentanyl, like, and I can remember when we were telling people that fentanyl because they didn't know, like fentanyl was relatively rare, and then the fentanyl's gone, and now it's very, for the first time the other day, I saw 6-acetylmorphine. I hadn't seen it for a few months. So is it about the ratio? Is it about like how much of the receptors have morphine and how many have fentanyl? And it's a ratio thing versus just the so it's okay if there's a ratio, but it's not okay if it's pure fentanyl. I don't know.
Yeah, there's definitely more to it.
And I think I'm going to go off on a limb because I know we don't have probably enough time for a case. So I'm just going to kind of wing this one. But I just want to acknowledge one of the other things that I think is really fascinating on this same topic is the manufacturer's label for Subligate. So the injectable version of this is that you should have somebody on 7 days of consistent sublingual buprenorphine at a dose of 8 to 24 milligrams daily in order for you to give the first dose of the 300 milligram Subligate. The theory is that you want them to be on a stable buprenorphine dose so that when you give the first injection, they don't get significant euphoria or precipitated withdrawal. Well, that's interesting because is that even relevant? For insurance purposes, it is, but does the science support it? And it's kind of this interesting concept of like, what's the right thing to do in that situation? The first dose of 300 milligram buprenorphine and Subligate gives you about the same equivalency to like 12 to 16 milligrams from like a mu receptor saturation perspective. So most people, if they're on 24 milligrams of sublingual buprenorphine with or without naloxone, usually have to supplement it with another 8 milligrams in sublingual for that first month. Otherwise, they'll feel like they're getting a precipitated withdrawal. People that are on lower doses of buprenorphine oftentimes for the first few days of the Subligate will feel like a bit of a buzz, and then it kind of normalizes. But I've now had a couple people who maybe they got like a dose while they were incarcerated and then left, but they have cognitive impairment or psychosocial instability, or the likelihood of them showing up to any degree of contingency management is so low that I just want to get buprenorphine in them. And we've been able to get them Subligate without proving that they've been on 5 to 7 days. And in many cases, it's actually worked out quite well for treatment retention, which is really the name of the game for mortality benefit. So it's kind of an interesting provocative view, especially when you're talking about like what Shelley's talking about, where, if you have like an overnight buprenorphine induction site, you're trying to get people stabilized, but you can't admit anybody to detox for opioid withdrawal anymore. Is it worth it? And can you get that covered? And it's kind of an interesting provocative theory is to say what's the right thing for any given individual, and it varies by circumstance. The topic of Subligate is a totally different conversation, but I think it's an interesting one.
Yeah, and then the other thing that I get worried about when I do the macro dosing with somebody who's used fentanyl within the last day is then on day 2 or day 3, are they going to get precipitated withdrawal with a lower dose of Suboxone?
And that goes back to like what's happening with the fentanyl.
Yep.
How do you interpret that study? There's only one.
Yeah, like it almost makes sense to do 32, 24, you know, to kind of do like a taper down
But
to
the
where you
fentanyl
want
wears
them to
off so
be.
fast. So like,
Yeah. They've
it should be
done
fine, right?
so far. Any other questions? I know I really enjoyed this discussion today because this is so much what we're trying to figure out on a daily basis with our patients. So does anybody else have any comments or questions or observed anything with people they're working with? Well, then we will wrap up. We just got confirmation that Nikki Giardina is going to be talking to us. Is that right, Michelle, next time on safer use and safer use
Yes.
education?
Yes, so education for providers, care providers about safer use, and that'll be on the 16th.
Thank you, everybody.
Great, thank you.
We'll keep